what do we do with kids with minor head injury? It's easy to know what to do with anybody with a major head injury as far as imaging is concerned, but the question comes up, what do we do with children? We've sort of solved the issue with adults, and I'll talk about one of the overlaps that we have with adults and kids, but kids are an issue. So what we're going to go through in the next 25 to 30 minutes is we're going to talk about what the risk is of intracranial injury. We're going to talk about what does it mean to have loss of consciousness or amnesia or vomiting or a scalp hematoma. What does it really mean as far as is it important or not? We're going to talk about the approach of scanning. Should you scan them all? And if you do scan them, are they safe to send home if the scan is negative? Or if we don't scan them all, how do we determine who should be scanned in children? So we're going to talk about this sort of overall. I did not write this chapter. Somebody else wrote this chapter. So I'm going to take a little bit of presenter's license, and we're going to bop around in this, sort of flip around more than what, it's not going to be in the order it's in, because I think it makes logical sense in a little bit of a different order. So what we're going to start with is abstract number 10. We're going to jump right to this idea of loss of consciousness and amnesia for event. One of the things that you'll look at in most literature, oh, by the way, before we start, one thing that really helps me when I practice is to understand what's the real risk here that I'm dealing with. If I have a child who has a minor head injury, okay, so they got hit in the head with something or they fell off of the monkey bars, or in that individual kid, what is the risk of their having a significant intracranial injury? Because I'd really like to know that before I even start. The range in the literature is 0 to 7%. However, if you really look at what we would all, I think as a group, consider minor head injury, which is the kid who comes in with basically a relatively normal mental status for the most part, not clearly loopy, not a GCS of 13 kind of kid. If you really just take the ones that we think are probably fine, but we just aren't sure, the range is 0.1 to 1%. So you're dealing with 1 in 100 to 1 in 1,000 children that we are approaching here to try to find that kid. So there will be 99 to 999 of them, of those kids, that will be fine. We are finding that one that's really a significant problem. Let's get into sort of what helps us here. So abstract 10 looks at this idea of loss of consciousness or amnesia for event, which we all use a lot in our practice, and it's used a ton in the literature to enter people into studies. You know, I got hit in the head, I don't remember what happened, or I got hit in the head and I got knocked out. That gets you into the study to look at whether scans are good or not. Is that really something we should be looking at? Is that really helpful to us? Abstract number 10 is a paper that's coming out of UC Davis. And the thing that's really important, keep UC Davis on the forefront of your mind when you look at studies on minor head injury in kids, because they are the center from which a huge bunch of multi-center studies are being done on kids with minor head injury. Nate Cooperman, who's a grad of Harbor actually, is the guy who's the PI for most of this, the primary investigator for this, and they're doing some really good data gathering and really good prospective studies. This is one of the things that they started when they published this. This is a 2004 paper that looks at over 2,000 children who had minor head injury. The median age in this study is 8. We'll come back to why age is an issue in a while, but the median age was 8. And they looked at a subset of children that had loss of consciousness and a subset of children who had amnesia or both. And they looked at basically 142 kids who had isolated loss of consciousness. So they got hit in the head and they got knocked out. They had 164 kids who didn't remember the event. And they looked at what was the likelihood of that child having a neurosurgical injury. Not one child had a neurosurgical injury. Now, what they didn't actually address in this is whether the CT scan was positive or not. They didn't subset that. But if you really get down to where the rubber meets the road, is this kid going to need to have an intervention of some sort? None of them did, not one. That being said, I think most of us still look at that as a factor because, and this is a pretty good paper. They did a really good study on this. Adult data is sort of parallel. That is in and of itself is not a great predictor of likelihood of intracranial injury. Is there something else that's better? Let's flip back to abstract number 9, which is actually not a paper that proves it, because this is an abstract that used skull x-rays for evaluating kids with head injury, intracranial injury. That wasn't a great study, but what they looked at here, if you look at the CT scan data that sort of parallels this, it's not this paper, but it's other papers that have been published, it looks at vomiting as a risk factor for an intracranial injury. Now this one, again, this is a review. It looks at skull x-rays. It doesn't demonstrate the point per se, except that the other data out there that looks at CT scans does show that vomiting increases your risk of having an intracranial injury. How much it increases your risk varies from study to study, and how many times you have to vomit also varies from study to study. Whether it's just one episode of irping after you hit your head at the on the monkey bars, or vomiting 6 or 7 times may make a difference. Not all the studies differentiate that, though. So vomiting is a predictor of intracranial injuries, probably a better predictor than is even loss of consciousness or amnesia for event. So that's sort of another little piece of information. How about a scalp hematoma? Abstract number 5, if we flip to that, looks at infants. Now this looks at little kids, and we're going to come back to the difference between a kid under 2 and a kid older than that. But this looks at little kids, and what they wanted to do in this particular paper is find all the kids with intracranial injury and then go look at what were the characteristics of those children so that we could figure out who they are. What they did with these kids is they found, first of all, they took 101 kids in this that all had intracranial injuries. They were all under 2. They all had intracranial injuries. 81% of these children had signs and symptoms that we would all agree, oh, they're sick. They are altered, they're irritable, they're throwing up, they are not normal. This kid clearly has a problem. What they found, though, is that there were 19 children of those 101 who had an occult intracranial injury. By just a quick scan over that kid, you would not have thought that they had something, but on scan they did. So by your quick exam, you're looking at them, how they're behaving, et cetera, you may not have picked it up on your initial eval. And they went back and saw, okay, how do we find these 19 kids? What was extra on our evaluation that we may have clued us into that there's intracranial injury issue? And what they found in this study is that 18 of those 19 children that you might not have otherwise picked up on your initial physical exam and evaluation had a scalp hematoma. This is where a scalp hematoma comes in and gets factored into children's imaging studies. It comes from this paper and several others like this that say most kids who have a significant intracranial injury, we can figure out initially when we evaluate them. But there are some that will go under the radar screen. They tend to be the younger kids. They're harder to evaluate. They tend to be kids under 6 months of age. And a scalp hematoma is a clue for us that they may have something in there that we'll find on scan. So loss of consciousness and amnesia aren't terribly good predictors, but they're often entry criteria for studies. Somebody who has vomiting, that's actually something that probably is important to know. And in little kids, a scalp hematoma may help us clue into the ones that we might otherwise miss. That's some of the sort of lead into this. Let's actually get into, though, scanning the kids. Go ahead.
Getting the CT is the issue.
Yes, because what we don't want to do, and this is why I'm going to get into sort of the next step of this. It's like, okay, the milieu risk is 0.1 to 1%. The things that help me kind of figure out which kids might have it are things like scalp hematoma and vomiting. You could make an argument, and a lot of people used to do this, is just forget it. I'm just going to scan them all. I don't want to miss any, so I'm just going to scan them all. If you scan them, let's look at a couple papers that look at that basically. If you look at abstracts 1 and 2, what they look at here basically is if you do scan them and you get a negative scan, are you safe to send them home? In adults, there are some issues about whether adults can have delayed bleeding. Because we all have little raisin brains in there. We have our stretched bridging veins, and we can have delayed bleeding. Do kids do that? The answer to the abstracts 1 and 2 is no. If you get a CT scan that's negative on a kid, they're fine. The only kids that fell out of this study were kids who were on were coagulopathic, usually on meds. They were put on warfarin for whatever reason. So if we build this up, it's like, okay, amnesia and loss of consciousness, not great measures for bad injuries. Scalp hematoma and vomiting, better measures. If I don't even want to think about it, maybe I'll just scan them all, and is that safe? You will basically, if the scan is negative, you're safe to do that, but is there a downside to that? And I would argue absolutely there is a downside to scanning every kid. Abstract 4 in that section right there deals with this. Couple things about scanning. You all know that there are downsides to scanning in children. One of them that's pretty straightforward to me is not infrequently the kids need sedation. That is not benign. Okay, that is not benign to do. You actually run the risk of aspiration, you run the risk of apnea and hypoventilation, et cetera. It's not bad. If you need to do it, it's fabulous. But if you don't need to scan a kid, I'd really not want to sedate a kid. Now, I have to tell you, the little guys, honestly, a lot of good tape, stick their head in that little thing, real quick helical scan, you can get them through it usually fine. It's the behemoth, could play linebacker 3-year-old. That's the problem kid, trying to get them scanned. You can't get them to hold still. At over 6, you can sometimes talk them through, sometimes 5, but it's that toddler stage that's so hard when you try to scan them. So that's one issue. Another issue is if I scanned every kid who bumped their head, I would have the queue a mile long to scan every kid who bumped their head. So it's not a good use of resources. And if I'm trying to balance the potential thrombolytic adult, the dissecting aortic aneurysm, the patient who might have a liver laceration, I'm trying to put everybody in the queue, where does the kid go? So that's not a great use of resources to scan all the kids, so that's not great. And then the cost is another issue, of course. The 2 other issues that come up, and this is controversial, are cognitive effects of radiating a little person's brain and potential carcinogenic effects of radiating a little person's brain. Let me tell you, there's a paper in here on cognition that fascinates me, and I have no idea how legit this is, although there's some parallel literature in leukemic kids who get their brains radiated as part of their treatment, as far as cognition effects of radiating a tiny person's brain. The abstract number 4 is a Swedish study, and what they did is back in the day, where people had hemangiomas of the face, they used to radiate them. Now we know that most of them shrink, a little laser, you're done. In the old days, they used to radiate them. What they did is, and the XRT doses really have a huge range in this study, but what they do in Sweden is you have to pass tests to get into increasing levels of education. So you have to actually have certain scores to get into university, to get into graduate school, and if you do the military, you have to actually pass certain cognitive tests to get niched within their military as far as what job you have there. What they did is compare radiated versus non-radiated guys to see how often they got into university, how well they scored, and where they got niched within the military as far as how they scored, and found that there was a significant difference in the kids who'd gotten radiated as youngsters and where they were able to cognitively function later. This is 2,500 people. This isn't 200. This is a big group of people. I'm not sure you can extrapolate that, although there is some data here in the US on these, again, leukemic kids who got their brains radiated as far as their cognition ability later. The other issue that comes up, and this is brought up a little bit in abstract number 3, is this idea of carcinogenic effects. We CT scan, the PAN scan, which we'll talk about when we talk about abdominal trauma later in the week. The PAN scan is just becoming universal. Basically, I figure what we're going to do with everybody now that they come in the ERs, they're going to go to triage, they're going to get laid on a gurney, they're going to get run right through a CT scanner, basically from their head to their toes. We'll diagnose every disease and find their weapons. Those of us that work in county hospitals will find those as well. We'll be able to, but that's not appropriate, and carcinogenesis is a concern. Let me give you data. No one knows for sure if all of this scanning is going to lead to an increased risk of cancer. We do know that radiation, if you get enough of it, does increase your risk, but we don't know where we cross that line when it comes to CT scanning. A head CT scan is the equivalent of 100 chest x-rays. So tuck that in your brain, because I find that a tremendously effective tool when a parent comes in and says, Johnny slipped in the kitchen and bumped his head on the edge of the cupboard, has a little tiny bump here, and I want you to scan his head. So we talk about the issues. He's otherwise looking great, looks otherwise completely fabulous. And one of the things that I mentioned is, well, a CT scan is the equivalent of 100 chest x-rays. Well, it is not at all infrequent where their parent will say, well, I don't want my kid given that much radiation. I don't want that scan. You can spin this however you want to. I tend to spin it in trying to convince the parent who wants the scan not to get the scan. And that's how I use this. It is a double-edged sword. One of the other issues that comes up is there's the kid you want to scan. That kid is not right. Something is wrong with this kid, and you need to get that scan. And then I really downplay the whole radiation thing, because I don't want the parent to say, oh, I don't want you to radiate, when I'm worried about something that's going to kill them today, not what might hurt them 30 years from now. So play this how you'd like. We don't really know the risk. We'll see 20 or 30 years from now when our cancer rates change or whatever. We'll see. But I would prefer to minimally radiate kids as much as I can using appropriate medical care. So that's the data there. So we talked about sort of where the risks are a little bit. Talked about if you scanned them all, sure, it's a safe practice, but it's an overutilization of resources, and there may be some downside carcinogenesis-wise, okay, and cognition-wise in little teeny guys. So that's our milieu over here. So what do you do? It's like, okay, fine. Diane, I still have to go to work tomorrow, and I still have to figure out whether I scan that 18-month-old. What do I do? There's a bunch of data in here. It's only actually, there's not a ton of studies in here, but there's some pretty good data in here that looks at children and what are the criteria to scan. What I would suggest to you is that an 18-month-old who has a minor head injury is not the same as a 10-year-old who has a minor head injury. And the problem with a lot of these studies is they will literally lump a 10-day-old in the same category as an 18-year-old as a blunt head injury patient. I think they're entirely different. I think they're two entirely different pools of patients. I can assess a 5-year-old. I can have them hop up and down on one foot and do fun stuff. I can assess a 12-year-old. I'm not so sure I can clearly assess a 6-month-old who rolled off the changing table, or an 18-month-old who's not quite able to be assessed yet. So I think we have two different issues here. Let's deal with the older kid first. Can I tell, and I'm going to give you age 5 and up because that's where the literature comes from, on abstract number 8. Most of you are familiar with, in the adults, the LSU or Haydel criteria for minor head injury in adults. What Haydel did is did one of the prototype papers for us to determine which adults with minor head injury need to be scanned and which don't. She's the one that came up with the sort of criteria of age over 60, a severe headache, persistent vomiting, suspicion of intoxication, trauma, physical trauma above the clavicles, seizures post-trauma, and short-term memory deficit. What she did with those 7 criteria is applied it to adults. She derived them retrospectively, applied them prospectively, big data, 900 patients. Found in adults, if the adults had none of those things, they were great to go without a scan. And it decreased scanning by 14 to 24%, depending which part of the study you look at. What she decided to do was see if she could apply these same criteria to kids. Now, to her credit, she said, I'm going to take kids that I can assess. I have to do a memory issue here. I have to be able to talk to these children. So I can't apply it to the teeny guys. But if I'm going to take my criteria that I already know work in adults and see if they work with kids, let's take kids over 5 and see what happens. Now, obviously, kids 5 are under the age of 60, so that criteria gets thrown away, and you are now down to 6 criteria. Okay, for kids, then it is a kid who has a severe headache, persistently vomits, she defined that as 2 or more times, clinical suspicion of intoxication, fortunately most 5-year-olds are not intoxicated, memory deficit, and do this kid level thing. You give them 3 things that they would recognize and see if they can remember that in a few minutes. Seizures post-trauma and significant trauma above the clavicles. If you use those 6 things, if the child has none of those, are these criteria good enough to apply to children? The answer is yes. Okay, she studied this actually in 175 kids ages 5 to 17. Basically found that 8% had abnormal scans if they had any of those criteria. She decreased scanning by 23% if you had not scanned the kids who had none of those criteria, and none of those children had an injury on CT scan. You can use these criteria. Now I'll tell you the conundrum that comes up with her criteria across the board, adults and children, is this concept of physical trauma above the clavicles. In her paper, that is anything that is trauma above the clavicles. That is a little scratch, that is a hematoma, that's anything above the clavicles. And in adults, that turned out to be very important. Even a little scratch was potentially predictive. This, by the way, the entry criteria is they have head injury, they have loss of consciousness or amnesia for event, and they have a normal GCS on presentation. That's entry criteria into this. Okay, so this is not the kid that's a GCS of 13. This is just a walk and talk and hit their head, either got knocked out or has amnesia for the event. That's how you got into this study in the first place, which is what most of us would agree with. Overall, this is a safe criteria to apply to kids over 5. So if you have memorized the LSU criteria already, you're home free. Okay, if you have those 7 things in your brain, you're great. The great age over 60 gets thrown out, you keep the other 6 in there, and you can apply that to kids under the age of 5. Abstract 8 has it all there for you. If the kid has none of those factors, you are safe to not scan. Those kids do fine. The problem comes up in the little guys. What do I do with the 3-year-old? What do I do with the 2-year-old? There are 2 papers I want you to asterisk. And by the way, if you want to take 3 papers out of this section and go home and read them that will help you, you want to circle number 7, number 8, and number 14, I believe. Yep, those are the 3 that will help you the most. Number 8 is the older kids. Number 7 is a paper that the AAP published looking at kids under the age of 2. Now, what they did in this, what Haydell and that did in that 5-year-old and older group is she studied kids. She actually applied it to real people. Abstract 7 doesn't do that. Abstract 7 is a bunch of pediatricians and pediatric neurosurgeons all went into a room, took all the literature with them, locked themselves in there, and came up with some recommendations. Not tested, just developed. But they're published by the American Academy of Pediatrics as guidelines for you on kids under the age of 2. And what they tried to do in these guidelines is figure out who were high-risk kids for a bad brain injury, and which kids could you get away with not scanning. Now, being pediatricians, God bless them all, they hedge. They say, we will give you these guidelines, and we'll tell you you don't have to scan it, but you still may miss some. Whatever. I'll tell you how you don't miss them in a second. But what they basically said was, here are the high-risk criteria. Kids that have decreased mental status or are irritable. Kids who are focal. Kids who have evidence of a depressed skull fracture or a basilar skull fracture on exam. You don't have to x-ray them, it's on exam. Kids who have seizures after their injury. Bulging fontanelles, the little guys, vomiting 5 times or more in 6 hours, God knows where that came from, and any loss of consciousness for more than a minute. This is what they came up with. And they basically said, okay, if children have none of those, you watch them for 2 hours in the ER, you're fine to send them home. So if your kid fell off the slide, hit their head, this is an 18-month-old, hit his head off when he fell off the slide, was a little bit out of it, but not for more than a minute, threw up once, but didn't throw up 5 times or more. You watch them in the ER for two hours, they're otherwise fine, they're out of here. Okay, you boot them out of here. They said you may miss a few injuries, unlikely, and so this is their guide. They never tested this, though. If you want data where somebody says, we looked at this, you want to go to the Nexus paper, and that's Abstract 14. What the Nexus 2 data did, Nexus 1 is the C-spine jazz. Nexus 2 is minor head injury. They actually didn't have as good a luck as they would have liked to develop a rule for Nexus 2, but they did subset out the children under the age of 3. Big database, by the way. The Nexus 2 is a huge database. It was 21 centers, huge database. Of this, 300 kids were in the study, and of them there were, 309 under the age of 3. This is now kids that got studied. Okay, these are kids that actually were real patients, and these are real little kids. They subsetted them out, and they looked at which kids had brain injuries and which one did you not need to scan. Overall, there were 8%, quote, important intracranial injuries in this group. That's a lot. Okay, that's more than the 0.1 to 1%. They actually had a pretty significant risk of getting an injury in this group, but they found that if children did not have any of the following things, clinical skull fracture, altered level of consciousness, neurologic deficit, vomiting that persisted, okay, 2 or more times, major scalp hematoma defined as 2 centimeters or greater in size, abnormal behavior or coagulopathy. The kid had none of those. In kids under the age of 3, no injuries were missed. Okay, all the kids had gotten scanned, no injuries were missed. They had none of those risk factors, no injuries were missed. The frustrating thing with all of this data is that what you have are, instead of saying, it's like Nexus. Here are the high-risk criteria. These are the people that will likely have an injury. If they don't have any of those, they are not likely to have an injury, and I can get away with not scanning. Bottom line, you must scan any kid who has any of the following. Any GCS less than 15, any altered mental status, including irritability in little teeny guys, anything focal on exam, seizures after the trauma have to be scanned, vomiting, particularly if it's persistent, any physical evidence of a skull fracture, in kids in whom you can assess it, any memory deficit, and a headache after injury all need to be scanned. In little kids, if they have a bulging fontanelle, they also need to be scanned, and if a scalp hematoma is greater than 2 centimeters, they also need to be scanned. If none of those are present, you don't have to scan. It'll decrease your scanning by about 14 to 23%, depending what study you look at. You will still be scanning a boatload of kids, and you'll still be scanning a lot of kids that don't have an intracranial injury. But that approach, you will not miss injuries that happen in kids. I want to have you not shoot the messenger. I would love to give you an easier solution to this, an easier approach to kids with head injury. It does not exist. The pediatricians are not willing to stick their necks out too far on this. I don't blame them necessarily, but we do definitely scan a lot of kids we don't have to. This will decrease our scanning of them by 14 to 23%-ish. You'll still be scanning a lot, though. And again, you have to remember all those criteria. I write them down. I have them written down. I carry them around in a little card with me, put them in my palm, so that I can just scan it, look down it, and say, oh, kid has this one. Darn, got it. I have to go CT this kid. Or kid doesn't have any of these. Mom wants a CT scan. Now I'm going to talk about those 100 chest X-rays and talk her out of it. So you're going to have to kind of approach it this way. And again, I'd like to make it cleaner, but this is about as clean as we have right now for head CTs in kids. Any questions? Yeah. Not necessarily, actually. And it's not headache where they got bumped. It's a true headache. Yeah, and that's actually parallel with adults. Adults are the same deal. A post-traumatic headache is an indication to get a CT scan. Same thing with kids. And the little guys, the problem is you can't really assess if they have a headache or not, but that's where you go on the irritability, the bulging fontanelle, is there a hematoma, the vomiting, that kind of stuff is what you can use better in the little guys.
And I wonder about the location of hematoma, like what hematoma is less concerning.
Absolutely. The Nexus criteria did differentiate that. They differentiated size and location. A frontal hematoma. So think about this. You have a kid. The only reason you would think about scanning the kid, everything else is negative, is that the kid slipped and fell in the kitchen and they have a 1 centimeter hematoma here. I mean, how many gazillion kids have you seen like this? You don't scan that kid. Okay, that's why they defined it as 2 centimeters. However, if they have a hematoma here, this is the high risk zone right there. Okay, that's the highest risk zone for anybody, adults and kids. That's the high risk zone. So those are the hematomas that you worry more about. But here, forget it. Little, forget it. Although, be careful with this too, though. You get the kid with the real true goose egg. You know, it looks like half a baseball on their forehead. They look like, Quasimodo. That, I would recommend scanning because that is above the 2 centimeter size. It's in an okay location, but that's a pretty big hematoma. Again, the yield is low, but that's a kid I would still scan. All right, clear as mud, huh?